Well, I'm Tom Peto, and I also don't have an anecdote about meeting Richard, although, Julian, you've known him longer. I guess I knew him earlier in my life, although you probably don't want to think about that. Anyway, so I'm going to talk about malaria a little bit. That's what I work on, and I probably work on this because of you. Although the two things I want to talk about, first, artesunate suppositories. So these emergency treatment, this is treatment to give children, especially children in Africa who have severe malaria, to save their lives by preventing them dying on the way to get to hospital, or meaning when they get to hospital, they can still be treated. And then the second thing is mass drug administration, which is something which is being piloted, so we don't have, I really shouldn't have been put in this session. We don't have big definitive studies on this. This is something which is under pilot in Southeast Asia as a potential tool for malaria elimination. Rory, I think actually it was you that got me to go out on this study supposedly for 3 months when I was 23, and I finished when I was 30. So it's all right for you guys asking for big numbers, but someone's got to sit in a village and recruit people. Anyway. So malaria should be curable. The main problem is people aren't getting effective drugs early enough to save their lives. And in the places where the deaths are occurring, and as Prabhat has said, we don't know how many people are dying from it still. And the turn of the millennium, it was estimated as something like 2 million, and now perhaps 500,000, but again, we don't know. But we do know a lot of the deaths are in the rural tropics, especially rural Africa, where people don't have access to injectable treatment. So a kid who has a fever perhaps develops convulsions or becomes comatose or prostrate or is just vomiting, so you can't give them oral medication. They may well have malaria, and if you don't get something into them and there's nothing injectable available, then they may die before they get proper treatment. So rectal artesunate was developed for this. It's not definitive cure. If you just give one suppository, it won't be sufficient, but it may buy you the time for them to get to hospital and get treated. There was a call to do a clinical trial on this, an individually randomized, placebo-controlled clinical trial where kids would either go into hospital as normal, they'd be recruited in villages with a fever, unable to swallow, and would be sent to hospital either having treatment started early or started late. And this was a study led by Melba Gomez and the World Health Organization, supported by many other people, and it was in Bangladesh and Ghana and Tanzania, which was where I was. And up on the top left, you can see Abdul Babika, who was the trial statistician, shaking hands with a guy called Makassi, or Scissors. He was the local Maasai leader. He's 6'7" and had got 25 kids. And we recruited one of them at the beginning. And this guy, like everyone in the district, was terrified of him. And we were just, oh, God, we hope this kid's all right. We were sort of getting ready to leave if anything happened. But it was fine. And then afterwards, he was our representative, and we carried on recruiting. We got thousands of people in the study, and it ended up being, I think, still the biggest randomized controlled trial of severe malaria ever. That's Dad visiting the village malaria workers. That's the guys on the motorbikes who'd go around and supervise the villagers. So I was fresh-faced and 23, and then came back age 30, never been on a publication, years before anything happens. But a proper study was done. I'm not, to this audience, going to say subgroup analysis are the best thing, but in this particular study, we randomized properly. There were large numbers of events, but we saw that in the kids who got to hospital early, because during this study, we wanted to do the best by them, and people were encouraging referral. The kids who got there very quickly, it didn't make much difference. But in the population that the suppository is designed to help, kids who are a long way from hospital, in that population, there was a big difference. And it's taken a long time, and this was a big study, it was quite well received and liked. It's taken quite a lot of time to influence policy, depressingly long, but there is now scale-up of this intervention in Africa. The 5 highest burden countries are distributing it. It is properly manufactured and distributed. So it was a long time from beginning to end, but anyway, that was my first taste of being involved in research, and it was really good fun. Anyway, so this is now 6,000 miles east of here in Southeast Asia, where I live, where the problem is are quite different. Malaria deaths have come down massively, and cases have come down massively, but there's emergent multi-drug resistance, which is a serious problem. Previously, this has spread from Southeast Asia to Africa and perhaps results in millions of deaths. And in Southeast Asia, this is a major barrier to elimination, which is what countries are trying to do at the moment. And so various different things are being tried. There's improvements in case management. So in Cambodia, which is where I work, that's essentially a village malaria worker program in about 4,000 villages, where you get early diagnosis with a rapid diagnostic test and treatment. Vector control, although unfortunately in Southeast Asia, the mosquitoes, the main vectors, don't bite at night, so bed nets don't work as well, but they do work. I mean, they're still really worth doing. And then other sort of more aggressive measures to try and eliminate rapidly while we have effective first-line treatments, including one thing which we've been piloting, which is mass drug administration. So that's presumptive treatment of everybody in a sort of defined area to get rid of all parasites and interrupt transmission like that. So we had the idea of malaria as being, the visible cases, the top of the iceberg, and then the more sensitive the test you use, the more malaria you see. We did some surveys, us and other groups across the region, and found that out of about 20,000 people, 13% or so have malaria parasites, and that's probably sustaining transmission. So in 4 countries, we did this pilot. And and the next thing, so getting blood from everybody to do these surveys, or getting lots of people to take medicine was quite a lot of work. It's not hard to get big numbers, but to get everybody inside a small area to do something at the same time, I mean, they're individuals, they can choose. So we had to sort of actually live in the villages and put on concerts and get the monks involved and take the medicine ourselves and this is Western Cambodia, so we're sort of hanging out with the old Khmer Rouge yeah, anyway, so the mass drug administration, I'm going to say that the pilot went well, but also one of the findings was that it was actually quite difficult for us to do it. It was harder than we expected. And there was one point where we had to sort of go out into the jungle and sort of shirts off and drinking with the local old Khmer Rouge guys, and they'd caught this little deer, and then they'd squeezed out its intestine to make this soup. And it was a sort of test of how willing we were to sort of meet on their level, and then they were going to help us. And so, like, people talk about eating shit. We actually did it for that study. I mean, it was disgusting. Sorry, that's not really appropriate. Anyway, and I thought maybe it was like rhino horn, like it'd be some sort of aphrodisiac. So I sort of asked the translator to say that, and the guy was, they talked with each other like, no, if anything, it puts you off. Like, but we got good coverage. We got like 90% or so. Yeah, I'm so embarrassed showing this slide after, especially the last presentation, but all of them, and this is tiny numbers. So it's about 4% of the people in these villages a year would have falciparum before we did orange. So we randomized, but the randomization obviously doesn't count for anything with 4. But after we did the MDA, which is 3 months of curative treatment with DHA piperacin, it's an ACT, artemisinin combination therapy, incidence did drop where you would hope, and then the following year there was nothing, and then with the control villages there was incidence, then it dropped when we did crossover treatment. But it's a pilot study. It's not a definitive study like some of the things you've seen earlier. I mean, and really, I think it's encouraging. It'd be nice to see it scaled up, but still, the main thing is early access to effective drugs. Yeah, MDA might be useful in some areas, but this is, we were asked to look forward, so please excuse anyway. So this was our gang, and then we got money from Bill Gates to do the study. So he and his wife came down to support us, and then they gave this speech, and then he went on TV in America, and someone messaged and said, oh, he's talking about your study. and he went on the Ellen show, which is the sort of, one of the most watched shows. Have you noticed, like, bastard, it was in that, I'm there, and then when he's on TV, MDA is being piloted. It may be very exciting. Getting rid of drug-resistant parasites in Southeast Asia is really important, and it's really interesting working on it. There may be ways we can improve MDA with different drugs, but anyway, that's not the thing to talk about. That's Richard and Julian. Everyone's been too nice about you, but not me. Actually, yeah. I mean, getting involved in all this stuff, I feel so privileged to have, even from a worm's eye view, worked on these studies, and it's been so interesting. And yeah, it's probably because of you that I've had the chance to do it. So anyway, yeah, thanks.